So the other case that I got to sit in on with one of our PTs in our Germantown location was actually a direct access patient who had a knee injury playing football. Dad reached out, wanted to see if we could get him in, knew that he could get into our office quicker than what they could get into an orthopedic, and just wanted our input on how to triage the situation and what the best steps were for this individual. So this individual, high school football player, was a quarterback. During the game, sustained an injury where he doesn't remember the exact mechanism. He just remembers during one play, he felt contact with his knee, felt out of the ordinary in regards to, didn't necessarily feel like a pop, but could definitely feel contact on the knee, was able to go back into the game after he came off the field for that play, was weight bearing, was ambulatory, was able to run, just felt noticeably different between the two legs. So they came in for PT, presented to PT, walking normally. If they did not tell you that he had an injury, you would not have suspected that just by watching him walk. Had no bruising, no swelling at the time of the appointment. They did report that it was a little bit swollen at the initial injury the week prior, but it had gone down significantly since then. Range of motion was nearly identical between the two limbs, and only very mild discomfort with end range flexion, no discomfort with end range extension. Was able to do all of your traditional orthopedic strength test without issue. Knee extension, knee flexion, hip ab and adduction without any issue. What I take from the hip ab and adduction, especially at a long lever, is you get to see their tolerance to varus and valgus stress at the knee as well. And they were able to do that fine. Could straight leg raise, could bridge, was able to do anterior step down tests with symmetry between the two legs. One thing that we did look at that though, he had some balance deficits, but interestingly enough, it was on the opposite leg. Digging a little bit deeper into that, he had a history of a high ankle sprain on that side. But I think that's also just another good thing to consider when you're doing these testing. There's going to be more things influencing the outcome of the test than potentially the injury at hand that day in that moment. But anterior step down looked fine. We were able to go through just some general movement patterns in the clinic. Able to do different squatting variations without any significant compensation, without any significant discomfort. The only thing that was kind of the sticking point with him was when we started to do pogos and started to do some of our impact-related activities, skipping, jogging. He was able to do all of them. He just said that it did not feel completely the same between the two legs. So just from a confidence standpoint, a little bit of apprehension between the two, but no demonstration of instability with that. All of the special testing for the knee with regards to meniscal and ligamentous pathology was insignificant. Really the only remaining issue was just subjective reports of, I don't even want to say discomfort, but just difference in feeling between the injured leg and the uninjured leg, both medial and lateral. My best suspicion for that was when he got contact, he believes he got contact from the outside of the knee. So some of that discomfort most likely just being from the contact and the impact and the trauma. And I would say if you had to classify this as anything, potentially just a very low level strain or low level irritation of the MCL or medial meniscus, but he didn't have any consistent patterning with testing to really definitively be able to say that. So we had told him and we had told Dad that in order for him to return to play, he needs to be confident to go back out in the field. He needs to be able to express the movement patterns that he needs to do as a quarterback and just general athletic movement patterns at a high performance consistent with what he could do previously, but also with the confidence to be able to do that as well. So we set him up with the home program, some of it geared towards just stretching, mobility for the knee, some of it some isolated strength training for the knee between bridging and single leg squat variations. And then we gave him a little bit of skipping patterns to do as well, both linear and lateral, to work on some force propulsion and absorption with the knee. He is coming back in 2 days from that eval, and we told him and Dad at football practice, hold off on contact, hold off on impact, go out there and just go through the motions. Take some handoffs, get some reps throwing the ball, feel things out in a very structured, less chaotic environment without the contact, without the impact. When you come back into the clinic Thursday, we're going to run you through a workout. We're going to see how you've progressed over 48 hours, see how well you can do these higher level change of direction and movement related tasks, but also keeping in mind that this is still just a structured, non-impact, non-chaotic environment that you would entertain on a football field. There was no immediate need for referral or no immediate need for imaging. So we told them that we will treat this as tolerated and that return to play will be based off of him looking like his pre-injury self. In regards to the upcoming game this week, that comes down to a variety of factors. One, how does he present Thursday with the ability to tolerate things in the clinic, but also how confident do we feel and does he feel that he can not only express what he did in the clinic with pads on in a game environment. And this is where you think of things such as it's week 2 in the season. How important is playing week 2 at maybe 85 or 90% and having that linger into week 3 and week 4? Or do we just take off this week, have our eyes set for week 3 where we can be 100% and be 100% moving forward at the end of the season? So with these decisions, you always rule out the red flags, and then I like to present the scenarios of this is the most aggressive way to go about it, that's medically appropriate. This is the most conservative way to go about it, that's also medically appropriate. Based on where you are with your individual situation, knowing what the worst case scenario and the pros and cons are of each, what do you feel most comfortable with? And I think it's a presentation of information, their risk profile with each decision, and then based on their sense of urgency and their preference, what makes the most sense for them to get back safely and perform at a high level.